like to invite our next speaker of today's CME, Dr. Niraj Raghani, sir. He is a renowned cardiologist and the director of Zenith Hospital, Amravati. He will be talking on changing trends in the cardiology. So I welcome Dr. Raghani, sir.
Am I visible?
Yes, sir.
Am I visible and audible, Vikram?
Yes, sir.
Thank you
Yes, sir.
very
You
much.
can go ahead, sir.
I thank IMA, Amravati, and both the Vikrams, Vikram Vankade and Vikram Deshmukh, for giving me this opportunity. Good evening, everyone. Very nice lecture we had today. Nice lecture by Anuradha ma'am and the previous speakers. So my lecture is on the role of interventional cardiology in current medical practice. As we are progressing and making advances in the technology, and in our cities like Amravati, we are getting new things day by day. So I thought let's keep a topic where we can touch on things where what we are doing in day-to-day practice in cardiology. So interventional cardiology is a procedure where we do a minimal invasive procedure with targeted instruments to treat the diseases of the blood vessels mostly. But in cath lab, we do other invasive procedures by other people like interventional radiologists to treat diseases of even the bones, the GI systems, and the brain also. But my topic will remain limited to the procedures related to the blood vessels. So, what are the advantages of these interventional cardiology or radiology procedures? That they are very minimal invasive. They does not need any general anesthesia, no large incisions. They are generally outdoor basis patients. Then we discharge on the same day. The minimal pain, minimal blood loss, and less expensive and less recovery time. So there are some non-vascular interventions which can be done in catheterization laboratory that we have, but I'm not going to deal with them today. So generally we come start from the heart, that is the bread and butter, and 99% of our work deals with the cardiac procedures. Though we do other vascular procedure also, but the most common procedure we do day-to-day basis is our coronary angiography and coronary angioplasty. So it's a small, simple procedure which gives us the data and picture of coronary arteries, and if there is any significant blockages in the coronary arteries, we do deal with them with different methods to relieve the blockages and to increase the blood supply to the myocardium so that the patient's angina and dyspnea can be relieved. So like this in picture you can see there is a lesion in the left anterior descending coronary artery which is been balloon dilated, and after balloon dilatation and stent deployment we can see the stent has been compressed or released and the blood flow has been increased. So similarly, like coronaries, we can do peripheral intervention where in this patient we can see a very diseased and atheromatous popliteal artery with a very tight stenosis just at the knee joint. And these kind of vessels, they don't need stent but just balloon dilatation. And now today we do have drug coated balloons or drug eluting balloons which are coated with the drugs like paclitaxel or sirolimus or everolimus, and they release the drug so that the atheroma does not regrow again. So these are some advances. This is an example done at our hospital, and we have dilated this femoral artery by a drug coated balloon, and after dilatation with the balloon we can see there is a dilatation of the femoral artery and there is a relief of the limb ischemia. So from blood vessels we will come to the cardiac shunt. So what we do in day-to-day practice for cardiac shunts like atrial septal defect or ventricular septal defect or patent ductus arteriosus, we can minimal invasively close these defects by putting devices. We can see here a ASD, atrial septal defect, and by putting a umbrella shaped device which is compressed and inside a tube which we call as sheet, and when we push the device, we open the left atrial disc and then pull it across the septum across the defect and release the right atrial side of the disc, and then we check the position on echo and release the device there. And slowly over a period of 6 months, these devices get endothelized, and there is a closure of the defect. So we can similarly we can close the ventricular septal defect and even the patent ductus arteriosus, and they are quite easy to do, very less invasive. Even I have done PDA closure in around 2.5 to 3 months old child, and it hardly takes time. Maybe I think 15 to 20 minutes, maximum half an hour is required after the child is under anesthesia effect to close the defect. So similarly, like closing the defect, another thing which we can do in current cardiology practice is doing balloon dilatation of the walls. In mitral stenosis or aortic stenosis, we can dilate the valvular stenosis by balloon. And now latest technologies are available where we can implant wall over the balloon and dilate and implant the wall across the defective wall. So it is called as transcutaneous aortic wall replacement, TAVR, TAVR. So this is the latest therapy available in the world for severe aortic stenosis, especially in high risk patients, those who cannot go for open heart surgery for valvular aortic stenosis. So from wall, we will come down to the electrical problems of the heart, like complete heart block, for which we can do a pacemaker implantation and relieve the complete heart block of the patient. Similarly, for aneurysms of aorta or aneurysms of great vessels, we can put a covered graft. Recently, I think in January or last December, we have done in one patient at our hospital, who was having a large thoracic aortic aneurysm, and we have put a covered graft. And this covered graft, what they do, they exclude the aneurysm from the blood flow, and slowly they get compressed and shrunken, and the risk of rupture of aneurysm reduces. So this is also very easy procedure which does not require large incisions. Or initially, when grafts were not available for aneurysm, there was the big vascular surgery is required, and it's a very high risk surgery. We can open other vessels like renal arteries. Here you can see the renal artery is completely compressed in the first lesion, and we can put a stent into the renal artery and open the renal arteries. We can do embolization of masses in the body to control the bleeding. If there is any vascular lesion like fibroids, uterine fibroids, or tumor where we suspect high bleeding risk in liver or kidney, we can do embolization, selective embolization of that lesion, tumor, or hemangiomas. And sometimes they automatically, after getting necrose, it's a treatment itself. And sometimes the mass gets shrunken and the surgeon then operates with a minimal bleeding. So that is another thing which we can do by doing in cath lab. Embolization is a material which causes necrosis of the tissue, and what we use generally, we use PVA particles or gel foams or coils to occlude the vessels. The PVA particles are very minute microscopic particles which go and block the capillaries of the AV malformations or the capillaries of the tumor or the growth. And by blocking the capillaries, it causes the necrosis of that area. If the tumor is having a large single vessel which is supplying that area, we can occlude that vessel by putting a coil there. So coil acts by blocking the vessel, while the PVA particle or gel foams acts by blocking the capillaries. So here are some examples, like this is a spleen. This is a patient of epistaxis, severe epistaxis, where we have closed the artery of the nose by putting up a coil here. And these are some examples of renal and splenic trauma where the patient was bleeding like anything, and we have closed the splenic vessels or renal artery to stop the bleeding. This is one case which we have done at our hospital. She was a patient of mitral valve replacement, and I was having severe menorrhagia. And for surgery, the patient's warfarin we could not stop because the patient was having mechanical mitral valve. So this patient was treated with a PVA particle embolization, and she was having large fibroids, and her bleeding stopped on the second day of embolization, and her size of fibroid also reduced. And after stabilization, after hemoglobin build up and blood transfusion and stabilization, we got her operated also by managing the anticoagulants of that patient electively. But in emergency, we control the bleeding by PV embolization. So this is very effective and very nice therapy to control the bleeding from fibroids in a high risk patient where the hysterectomy could not be done immediately, or patient is bleeding like anything and we have to stop the bleeding. Embolization can be done for renal, for varicocele, for pelvic embolization post trauma, or sometime where there is GI bleed and gastroenterologist could not control the bleeding by endoscopy or colonoscopy. We can go into the splanchnic vessels or into the mesenteric arteries and can cause necrosis of that area and can stop the bleeding for life-saving emergencies. Um, Another emergency is bronchial artery embolization. Generally, it happens. The hemoptysis occurs in patient with post-tubercular patient, where the patient is having large cavities and one of the blood vessels open into the lung cavity, and patient coughs out blood. And there is if there is a significant amount of bleeding occurring, significant amount of hemoptysis occurring, and it is not getting suppressed by drugs or other medications, we need to take the patient into the cath lab and do a super selective injections into the bronchial arteries, and if we can see any malformations there, uh, which are the bleeders, we do inject coils or PVA particles or sponge to stop the bleeding. Sometimes in malignancies where the mass is big and there is a metastasis, and patient is on chemo or radiotherapy, and the surgeons want to reduce the size of the mass, we can do chemoembolization of that masses, which acts by reducing the blood supply as well as by delivering the chemotherapy to that site. And it is generally used by gastroenterologist or interventional radiologist, especially in the liver cancers, because liver is having dual blood supply from the portal vein as well as the hepatic artery. So if we inject by hepatic artery or portal vein, uh, the neck rather than necrosis, it generally causes more of chemotherapy related effect. So uh, this was all about the putting up the devices inside the blood vessels and opening up the vessels and doing what we can do. Sometime when we cannot deal with things and there are a lot of thrombosis and patient comes with acute ischemia, any limb ischemia or organ ischemia, we can super selectively go into that vessel and do thrombolysis also, and we can dissolve the clot and establish the blood supply. Recently we had one patient who was post GI surgery, and the intestine was a part of intestine was removed because of ischemic necrosis of the that intestine. He again came with second episode of GI ischemia, the intestinal ischemia, and the surgeon said if we remove the remaining part of intestine, it will be very difficult for the patient to survive. So in that patient, we did intravascular thrombolysis, and post thrombolysis, his symptoms improved, and we could save his intestine, and the patient is doing good. Nowadays, we are at Amravati also, we are doing a lot of venous procedures, especially in patient of, I am doing a lot of patient with deep vein thrombosis, where we are doing thrombus extraction from the veins, we are doing thrombolysis inside the veins, and we are doing dilatation and with balloon and stent of the venous stenosis to improve the venous outflow from the limbs. And we do also here uh, laser therapy for varicose vein. So these are all vascular intervention in the veins which we can do. Another important thing which we can do in cardiology or interventional radiology is the removal of the foreign bodies from the blood vessels. Sometimes we get calls that while putting up the sheets or devices, or while putting up a dialysis catheter, the wire we left inside or wire went inside the blood vessel and we are not able to remove. So we can go from another site, snare it, snare the foreign devices. We can hold up the foreign devices and remove them outside. So There are a few other things that I will not go into details. But what is new that is happening in interventional cardiology, now we are having intravascular ultrasound that we can see inside the blood vessels, what is happening inside the blood vessels, how is the blockages, how is the atheroma, whether the atheroma is having a thin cap, it is a ulcerated plaque, it is a high risk plaque, whether it is having high chances of rupture, whether it is a calcified blockages, what kind of therapy it needs. If the block is very much calcified, we cannot open it by just doing a balloon or putting up a stent. We need to shave the calcification by doing either laser atherectomy or diamond burr ablation, that is called as rota ablation. So intravascular ultrasound is very advanced imaging for the blood vessels. Second new thing which is coming up now is the fractional flow reserve. And this FFR or fractional flow reserve tells us whether any blockage of the heart or coronary artery needs any therapy or not. That means if a patient comes with 70-80% blockages, but the symptoms are not very typical, or the patient is having atypical symptoms like atypical chest pain and it does not fit into the blockage, whether that blockage is causing that symptom, we can decide by measuring the pressure across the lesion, across the blockage. So if there is more than 20% pressure drop across the lesion, that means there is a significant ischemia caused by that blockage and we need to deal with that. So rather than going with the anatomy or percentage of blockage, whether it is 40%, 50%, 80% or 90%, we do rely more on physiology, that is a drop of pressure across the lesion. And if there is significant drop of pressure across the lesion, we do need to deal with that lesion irrespective of the anatomy of that lesion. So this is very good thing where even where the patient is having multiple lesions, like patient is having 4-5 lesions of 70-80%, and we don't know whether we should send that patient for CAPG, or there may not be there may be only one lesion, one blockage which is causing problem, and we can deal with that lesion by just putting up a simple stent and not sending that patient for bypass surgery. Newer therapy are rota ablation, where we are going to ablate or burn or debulk the calcium of the blockages to give a better results with angioplasty to expand that lesion properly, so that the long-term results should be good. Patient should not come with re-stenosis or repeat blockages in that area. So we need to remove the calcium from the region by doing rota ablation. We can do laser atherectomy by burning with the laser of that calcium and opening up the vessel. So in our hospital at Amravati, we do have a very good cath lab, and we are doing a lot of complex procedures, including peripheral procedures. And to help us, we have equipment like intravascular ultrasound, FFR, rota ablation with us. And in most of the cases, what we are doing femoral, while removing the sheath, we do transcutaneous closure of the puncture site of the blood vessel or the artery without giving compression, so that patient should be comfortable and patient should not develop any hematoma. So these are the latest advanced therapies which we can do, and slowly we are bringing them to our city like Amravati. And I think I keep just this topic to get a brief awareness of what we can do in interventional cardiology or in cardiac catheterization laboratory. Thank you very much.
Thank you very much, sir, for a wonderful talk. Now, going ahead, I would like to request Dr. Ashish Sabu, sir, to be our next speaker for today. We know that